And, as we begin, as usual, there are no financial relationships to this program, to anything presented either in the past or in the present. As I present this, occasionally I will use brand names. But again, I think the reason for doing that is to maybe clarify or differentiate between various formulations and for ease of practice. And because our patients are going to be using brand names, but I don't have any financial relationships to report. So again, today's presentation, one of our core talks that we do each 12-week cycle, details of formulation and dosing of buprenorphine. This was the talk. I always like to start off by kind of giving a history of it. Initially, it was not a part of our core group of presentations we did. But one of our early study participants, ECHO participants, really recommended that we start doing a talk that covered kind of the nitty-gritty, as he called it, of dosing and different formulations of buprenorphine that were available. So that's really how this talk started. And it's kind of gone through revision. And in fact, I revised it a little bit more this morning. So I pulled up the updated slides, and they're very similar to what you all should have received, but there are a couple of changes. So at the end of this ECHO, I will send out the new presentation to Rana, who can then mail it out to everyone. Thank you, Rana, for that. So I think I just updated it a little bit to reflect some newer studies, essentially. Right. So we're going to go over, basically, it's exactly what the title says, right? We're going to go into the details. What are the different formulations available? What are some similarities? What are some differences? How do you start someone on the medicine at home and in the office, right? We're going to start creating a plan for managing the process of medical withdrawal from buprenorphine as well. So we're really going to delve into some of these details. So this is going to be, for the non-prescribers, a very medication-driven talk, but I think there is still hopefully, value in, I think, all the clinical team members becoming familiar with it. As we talk to our patients to help them guide between different formulations to help them make these choices. So I'm going to start with formulations. And I took this slide, and this is one of the slides that's different. I took it from PCSS, which is the Prescribers Clinical Support System, which is the federal sort of the website and program created for standardized training of treatment of opioid use disorders. So this goes over many of the currently available formulations. Some key things here to go over. The first, of course, choice that we make is the mono product, which is buprenorphine alone, or the combination medicine, which is buprenorphine combined with naloxone. And remember, as we've covered in other talks before, the naloxone is often added to buprenorphine only to prevent diversion, kind of misuse by injection, right? Parenteral misuse of prescribed medication. Because if someone decides to crush up and inject prescribed combination medicine, for example, the naloxone, which is a very potent and rapidly acting opioid antagonist, would become effective, would kick in and throw the person into withdrawals. The combination formulations also tend to be less reinforcing. So one of the take homes for those who are just starting out, for those who may be new, or maybe those who are not prescribing, is that the standard of care is that for most of our patients, we use the combination formulation, which is buprenorphine combined with naloxone. Comes as sublingual films, sublingual tablets of there's generic, there's a different brand name, there's also a buccal formulation, as you can see, and they all have some differing ratio of buprenorphine and naloxone, right? But the idea is the same, that the naloxone is there really to minimize misuse by injection. The most commonly available formulation, at least here in New Mexico, that I find are these combination films, which are available under the brand name Suboxone, but are also available generic. In fact, in my practice, I generally prescribe the generic combination films to most of my patients, right? And as you can see, this commonly available sublingual films have a ratio of buprenorphine to naloxone of 4:1. So for example, if a patient says they take 8 milligrams of Suboxone, more appropriately, I guess, or more precisely, what they're taking is a film that contains 8 milligrams of buprenorphine combined with 2 milligrams of naloxone. right? So generally we use the combination medicine. That being said, I did want to touch upon the mono product, the buprenorphine mono product. It is available as generic tablets. The brand name for it is Subutex, but again, it is also available generically. That comes in 2 and 8 milligram tablets. The only time I really use it in my practice is during active pregnancy. And even that's starting to change nationwide as more data becomes available. Many prescribers are starting to use the combination medicine even during pregnancy. And even at UNM, that's starting to happen more and more. And I'll keep you guys updated on it. There is a buprenorphine implant that has been FDA approved. So it's essentially these rods that are implanted in the upper arm once every 6 months and release small amounts of buprenorphine over the course of that 8 months. Caveat, that went off the market several months ago. It remains FDA approved, but it's no longer available because there was no one was using it. Patients simply didn't want the implant placed, so there was no market for it. So the drug manufacturer that was making it no longer manufactures it. There is an injection that we use quite a bit, the Sublocade injection, which is a once a month, once every 4 weeks subcutaneous injection given in the abdomen. The way you start it is the first 2 doses are 300 milligrams. And after that, you can keep the patient at 300 milligrams or go down to 100 milligrams, depending upon their need and their response and tolerability. Another new formulation of subcutaneous injection is also going to go on the market very soon, we believe. And it's going to be available under the brand name Brixadi. And the nice thing about that one is going to be that it's going to come in weekly as well as monthly formulations and in many different doses. The weekly formulation of this new upcoming medication will be 4 different doses, and the monthly formulation will be 3 different doses. It also will not need to be refrigerated. So I think that's going to open up a lot more treatment options for using this long-acting formulation of buprenorphine mono product, right? So in general, some take-home points: the combination medication is the standard of care for most of our patients. The naloxone is really there only to decrease the injected abuse of the medicine. And let's see, the mono product we generally use during pregnancy, and I suppose if someone has a documented allergy to naloxone. In terms of the film or the tablet, as you can see going back here, and the combination medicine comes both as a sublingual film as well as a sublingual tablet. They both work about equally well, right? So efficacy is about the same. Tolerability is similar, although the film tends to dissolve quicker. So it's largely driven by third-party payer consideration. What is the pharmacy going to stock, and what will the insurance pay for? I included this slide really because I hear this idea of sometimes providers saying, why shouldn't we just go with the injectable formulation for most, if not all of our patients, right? Because there is no diversion risk with the injectable medicine, right? The patient comes into the clinic once every 4 weeks, they receive the injection, they're on their way. So on the surface, it sounds kind of like an attractive choice, right? To kind of convert most people over, but it's not so simple, right? There's more to consider. I don't recommend using injectable for all of our patients. I think we should be doing careful patient selection for using injectable. One reason is that there is minimal clinical experience with the injectable, right? We simply don't have the clinical experience that we do with the self-administered sublingual tablets or the sublingual films, right? Which remains the current standard of care. It's available in many doses and formulations. And right now, that's not the case with the injectable. Though, as I mentioned, this is going to be changing. We're going to start having many different formulations, many different doses, which will again make this more feasible. Also, the closed distribution system poses a major barrier, right? First of all, it's very expensive. The higher cost, the injectable can be, $1,500 a month, for example, right? So the cost really adds up. And because of the closed distribution system, the medication can only be ordered for a specific patient, right, which will then get shipped over to the clinic where the medicine will be administered. So the clinic also has to be enrolled in a REMS program, or the provider's DEA has to be associated with that clinic. And that medicine is stored and then given to the patient. So it's a complicated and expensive system, right? On the other hand, the compliance is likely better. and diversion risk is lower with the injectables. So it's a patient-centered decision that I recommend making, in a broad-based way, in collaboration with the patient. I recommend using it, for example, when compliance with the daily medication is an issue, or we've had patients in whom having this medication, the Suboxone take home, place them at risk. So for example, patients who were in a facility that would discharge them if they were on buprenorphine, believe it or not, that still happens. So in order to ensure that they stay on this potentially life-saving medicine, we switch them over to the injectable formulation. There is also growing evidence that the injectable medication, the injectable buprenorphine, can actually play a major role in sort of rapid inductions, rapid initiations in patients who have been primarily using high-potency synthetic opioids, such as fentanyl and its analogs. It's still experimental, but I will present a couple of slides at the end of this talk, right? So now, then I'll go briefly into initiation at home and in the office. This is covered in the buprenorphine waiver course. So for many of you, this may be a review. I'm really going with at-home initiation because it really is the standard of care, right? So is it safe? Is it effective? Initially, when buprenorphine was marketed, the idea was that everyone would be started on buprenorphine under direct observation by a provider within the provider's office. But that's really shifted. As early as 2009, Josh Lee was reporting that many primary care doctors were doing home initiations of buprenorphine. This was a follow-up study that was published in 2017. And since then, even more literature has come out, essentially showing that home initiation onto buprenorphine, unobserved home initiation, is just as safe and just as effective as office-based initiation carried out in a more traditional way. So for most of you guys who are primary care doctors, home initiation is going to be the way to go. I do recommend doing some patient selection. Consider, none of these are hard and fast rules, but consider excluding from the home initiation process patients who may have low tolerance, right? Who maybe have been using very low amounts of opioids, or occasionally patients who are transitioning from methadone, because there is a higher risk of precipitated withdrawals when someone is switching from methadone onto buprenorphine. Patients who may not be able to follow directions, right, for home initiation, such as patients with cognitive impairments or untreated severe psychiatric conditions or even suicidality. And occasionally we have patients who have no prior bup experience, or maybe they have bad experience where they took it on their own and went into precipitated withdrawals. So they're very fearful of the process. So sometimes for those patients, doing it in the office can just be comforting. But for most patients, home initiation is appropriate. The way we essentially do it is very similar, right, to what we do in the office. We provide education to our patients. We send them home with a prescription for a few strips of buprenorphine. I tell them to wait until they're feeling very lousy. I give them the magic numbers, at least 12 hours since the last use of short-acting opioids, at least 24 hours since the last use of long-acting opioids. I also tend to send them home, and not everyone does this. I tend to send them home with a copy of the subjective opioid withdrawal scale, or SAWS, and tell them, once you waited long enough, give yourself the SAWS and target a score of at least 17. And when you're there, start with a 4 milligram dose and keep redosing with 4 milligrams every 1 to 3 hours if withdrawals continue, for a total dose of 12 to 16 milligrams on day 1. And okay to call the clinic in case of precipitated withdrawals or problems. So you can get people started very rapidly. This is a copy of the SAWS scale. Day 2, you take a total of day 1 in the morning. If they took less than 16 on day 1, contact the clinic to check in. And later in the day, if you experience withdrawals, take additional 4 milligram doses until you're comfortable, or until you reach a maximum of 16 milligrams a day. So fairly straightforward process, right? And we can get people to that target dose of 16 milligrams within just, within just a couple of days. And day 3 is actually rarely needed, right? How long to wait? Again, just a reference slide. If someone's been taking short-acting opioids, we recommend they wait for at least 12 hours. If they've been using most long-acting opioids, at least 24 hours. But with methadone, at least 36 to 48 hours, right? If they are transitioning from methadone, you first tend to bring them down to 40 milligrams or less of methadone for at least a week. Then the patients go without methadone for about 48 hours, during which time we provide symptomatic management, right? And then we start the buprenorphine low and go up slowly. And that's generally the process we use. In case precipitated withdrawals do happen, I think the first bullet is important. We like to discuss the risk and management ahead of time. I tell my patients that in case this happens, stick with us because we know how to treat it. And the treatment is we provide medications for symptomatic management, but we simply provide more buprenorphine, right? In hopes that the more buprenorphine, the raising dose of buprenorphine will provide enough mu-opioid agonism to overcome the withdrawals that the patient may be experiencing. So that's a little bit about home induction. I do have a couple of slides on microdose inductions, which many of you may have heard about. This is becoming increasingly common. In fact, we've had case presentations during our echo where the presenters have talked about carrying out microdose inductions. We certainly do it as well, but the data on it is fairly limited, right? There is no randomized controlled trials that have looked at microdose inductions, but in clinical practice, this is starting to happen. The idea behind microdose inductions is that you provide tiny buprenorphine doses, gradually building up in a stepwise manner to reduce the risk of precipitated withdrawals and pain. So the idea is that if you're slowly going up on the buprenorphine dose, each day the buprenorphine will displace, because of its higher mu binding affinity, a slightly higher amount of the opioid that the person may be taking. So over time, it's essentially a cross titration that's carried out. In my experience, this approach may be especially useful in patients with chronic pain or those that are unable to stop using illicit opioids. The key difference compared to the traditional ways of initiation is that microdose initiations do not require withdrawal, that opioid-free period prior to the initiation process, right? And the opioid can be tapered or even stopped once the initiation is complete. There are many different methods of microdose inductions out there. Some of them utilize just the sublingual film. Some of them utilize the transdermal patch. Some utilize the buccal formulation. This is a classic way of doing it called the modified Bernese method, where you can see that on day one, you're starting with a tiny dose of 0.25 milligrams, right? So a 2 milligram strip of Suboxone cut into eighths is really what the patient is starting with, and slowly building up, as you can see, until they get to about 12 milligrams a day. And then whatever opioid they've been taking is tapered off rather quickly. Just some thoughts on maintenance dosing, which are covered in a lot more detail in other presentations. FDA maximum is 32 milligrams, but most insurances will cover up to 24 milligrams. That being said, we have patients in our clinic who do require the 32 milligram dose. And when we try to go lower than that, they have withdrawals or cravings or decompensate, in which case we wind up really advocating for our patients, the insurance company, to ensure that they get the dose that they require, right? The duration of the prescription, how long should the prescription be? No hard and fast rules, but in general, we tie it into how the patient is doing, such as remission, treatment compliance, functional goals. In general, at our clinic, we tend to start with weekly scripts for about 4 cycles, then 2-week scripts for about 4 cycles, then monthly. And for our stable patients, we go up to monthly with a refill. Because buprenorphine is Schedule 3, technically you can go up to a month with 5 refills, right? That is legal. Diversion management, we have a whole talk on, but in general, important to do urine drug screens and prescription monitoring, which is also the law in New Mexico. Safe storage, lock boxes, and ensure that you're providing naloxone. In the remaining 5 minutes or so, I want to touch upon, again, we have a whole other talk that we do that delves into HPSOs, which stands for high potency synthetic opioids, such as illicit fentanyl. So I really want to just provide this overview. First of all, does buprenorphine work? Is there a role for buprenorphine in treatment of patients who have been using illicit opioids? And the answer seems to be yes. It appears that, if you look at patients primarily using heroin versus patients who have been primarily using fentanyl, the treatment retention and abstinence rates when they're treated with buprenorphine appear about equivalent. So it tends to work about equally well. We don't have great data on it, but the big challenge with this population has been, how do we get people started on buprenorphine? Because clinicians from around the country and here in New Mexico are reporting a higher dose of precipitated withdrawals, or higher incidence rather, of precipitated withdrawals in patients who have been primarily using fentanyl, right? So how do we do it? And there are two different schools of thought. Very commonly, we wind up using this microdose approach. Start low, go slow. So first we wait a little bit longer, right? So until the COW score is about 13 to 15, some patients are even waiting 24 to 48 hours after last using fentanyl, if they've been using it regularly, until they hit this COW score of 13 to 15, which puts them in a moderate withdrawal rate, moderate opioid withdrawal range. And then they're starting with kind of these low doses, 1 to 2 milligrams every 1 to 3 hours, and building up from there. And that's one strategy people have been using. So kind of starting low, but with more rapid dosing or more frequent dosing to build up to 8 milligrams twice a day by day 2. And some people are reporting that many patients who have been using fentanyl, because they have a higher baseline tolerance, may need to build up to 24 milligrams a day, and 16 milligrams may not be adequate. And some patients may even need methadone to help them with this. This was a paper that was published last year, just a case series, which really advocated for this this low dose approach, where essentially they found that patients who had been using fentanyl, if they were given multiple 2 milligram doses of buprenorphine, as opposed to 4 or 8 milligram doses, they tended to do better. And they were more successfully able to get onto buprenorphine. Then some people have taken this macrodose approach, right? This was the initial paper published where essentially, they took patients who had been using fentanyl, started giving them high doses of buprenorphine, and very quickly got them onto the injectable formulation, the sublocade buprenorphine, which also releases high amounts of buprenorphine into the bloodstream pretty rapidly. And more recently, this paper was just published this year, a follow-up paper, where essentially, so if you had patients who had been using fentanyl, these patients, right, but they targeted a COW score of 8 or 9, right, 8, which is what we do with other opioids. Then they started giving them buprenorphine quickly to build them all the way up to 24 milligrams on day 1. And at the end of the day, they got them the injection, the 300 milligram sublocade injection, and found good outcomes with this, right? So there are two different ways people are doing it. There have been no head-to-head comparisons. There have been no randomized controlled trials, right? But I think to me, the take-home point is that we are seeing a lot of fentanyl in our communities around New Mexico, around the country, and our traditional ways of starting people on buprenorphine are maybe inadequate. They're neither here nor there. And so think outside the box. For many patients, the microdose approach may work. It's certainly more feasible. It's certainly more practical, right? On the other hand, if that does not work, then we wind up resorting to the macrodose approach, essentially getting an injection in the name of the patient to the clinic, and then taking this approach to get them on buprenorphine. So we'll see how all this pans out, but this is kind of where the data is. Lastly, just a note on withdrawal, right? There's no great data to give us guidance on how long to treat a patient with buprenorphine naloxone maintenance. But in general, patients with opioid use disorder tend to have high rates of relapse, as we often talk about, when they're discontinued from this treatment, right? So practically, what I talk about is this, that if we do have patients who want to withdraw from the medicine, who want to come off of the medicine, these are some practical tips I talk about. I tell them to wait until functional goals are met. Their lives are more stable, they have more stable social networks, because all those things are going to play a role in how they do as they taper off of the medicine. Do it gradually at your own pace. Remain engaged in treatment, in therapy, in 12-step programs, even as you taper, and consider naltrexone depot injection once the withdrawal is complete. Interestingly, next month, we're going to start recruiting for a study here at UNM. It's going to be a big 5-year study funded by NIDA with many sites around the country. But one of the things it's going to look at are different strategies for successful taper off of buprenorphine in patients who are stable, who are doing well, and are interested in coming off of the medicine. So we're gonna see, it's gonna go on for several years, but hopefully in a few years, I'll be able to give you more precise information about this. But for now, this is kind of how I approach it, really making it a patient-centered conversation. So I will stop here, Rana. I think